Hello. Thank you all for joining us today. This is Dr. Mario Chorak. He is a Seattle native, having grown up on Vashon Island and then attending the University of Washington for his undergraduate degree. He received his dental degree from the University of Kentucky College of Dentistry. He then earned his certificate of orthodontics and dentofacial orthopedics from Oregon Health Sciences University. Dr. Chorak has received multiple American and international awards in dental research and was inducted into Omicron Kappa Upsilon Dental Honors Fraternity. He has published articles for the American Association of Dental Research in the Journal of Clinical Virology. Dr. Chorak has served as a secretary and is now the vice president of Washington State Society of Orthodontics. He is also a member of the American Association of Orthodontists, the Pacific Coast Society of Orthodontists, the Washington State Society of Orthodontists, the American Dental Association, and the King County Dental Society. Please welcome Dr. Chorak.
Well, I'd like to thank everybody for joining me here for an hour. I was on the webinar last Friday and listened to Luis talk about the biomechanics of the Carriere Motion appliance. We're going to dive into more difficult cases today. I'm going to do a little review on the biomechanics involved with the 3D Carriere Motion appliance, and talk about how it's really changed the way I practice orthodontics today. All right, so we're going to take a look at when we talk about the definition of why we choose the motion appliance here. And when the reason that really hits home is that we get most of the difficult, the hardest part of the bite correction done initially. So when the patient's motivated, cooperation is great, compliance is great. Those are the things that we've seen in our office, really streamlines these cases rather than at the end when the patient's burnt out. So we take a look at the biomechanics, what's occurring here. So when we have people that have excessive overbite crowding, rotated molars, we're able to get these rotations corrected. We're able to upright the molars, and we're able to distalize the molars, premolars as well, and the canines. We get separation of the interseptal fibers there in the anterior region, and we basically are able to create more cases without extracting teeth and really not having to do surgery in a lot of these cases if you get them while the patient's growing. So you get this increased space creation that occurs. We take a look. This is the things that you should see usually within 6 weeks. We see our patients on 6-week intervals. You should see the distalization there of the canine, getting into a Class I platform. You should start to see spaces developing between the laterals and the canines. It doesn't always happen, but it should happen. And the one thing that we check in on our patient is the mobility of the canine. If it's not mobile, they're probably not wearing their rubber bands enough. They're not changing them enough. So those are the things that we look at that first appointment. But we've had patients within 6 weeks, take a full cusp Class II canine relationship and drive it into almost a Class III relationship. So it does happen fast if they're really compliant. So we take a look here. These are the things that we should see. So if we take a look here, we can kind of see, just like we talked about, get distalization of the molars, we get uprighting of the molar, we get almost like a Frankel effect there with that arm. You can kind of see we get expansion as well in the premolar area. And then you look at the space creation in those areas there, so we're getting the separation of the interseptal fibers in those areas, and really able to upright the incisors too on Class II Div II cases where the SX retainer will kind of upright those teeth. So those are some of the things we can see, and that's the reason why I think it's called the Motion 3D appliance. We're really affecting all 3 planes of space. So if we look at here, I'm just going to kind of run through, sometimes the video helps kind of demonstrate what's occurring. But if we look at here, we're going to see some profile changes that are occurring. We get better lip balance that occurs. And we can see here in the video, we're basically showing how we're going to get some distalization of the molars. Some of the things that we do in our office is a lot of the same day starts that we do in our office. We will actually scan the patient, scan the patient for a lower SX retainer. We'll send it off to our local lab. We don't 3D print yet, but we'll send it off to our local lab. They'll fabricate 2 SX retainers, and then we have the 3D model. So, if the patient happens to lose 1 or 2 retainers, we have the ability to make more. So here we talk about, friendly airway orthodontics here. Sometimes we can get opening of the airway. Dr. Carriere talked about recapturing the disc. We see that a lot in patients. People that have TMD symptoms seem to get better with this appliance. Never seen them get worse. And then you can kind of see the case is now prepared for aligners or braces. So you take a look here. We talked a little bit about some of these self-ligating mechanics, consolidating the anterior spacing. I know Dr. Carriere talked about, placing hooks distal to the laterals to help retract space. This is a whole nother topic that I'd be happy to talk to you about with self-ligation mechanics. I've been using self-ligation mechanics in my office for the past 14, 15 years, and that's all we use in our office. So that was just an overview there. I think one of the things, the hardest thing to when we implement motion in our practice is to be okay with development culture of same-day starts. We've seen that in our practice in the last 2 to 3 years, that our practice is now able to actually accommodate people for same-day starts, where we have holes in our schedule to where we can get people started right away. We talk about correction. When we measure these appliances, it's always to the mesial third of the cuspid. Class 2 cases, what we'll do is we'll bond the molar first and then the cuspid. On class 3, it's just the opposite. We bond the cuspid and then the molar. I use shorties a lot, not always, but a lot on high cuspids. Usually cuspids are displaced either buccally or lingually. And overcorrect, you'll see some cases that we're going to show where we overcorrect a modest amount. Follow the elastic protocols. We'll talk a little bit more about that. But I really believe that this appliance is really, really the go-to AP corrector out there right now. So when we look at a shorty, these are the things that I look at is when the canines are obstructed, high, when they're severely rotated mesially, or they're extruded, or displaced buccally or palatally. So what we've seen in our office is this is the biggest thing, is that we've seen a huge significance in the amount of time, happy patients, happy staff. Patients notice the benefits like we talked about early on in their treatment, and they can see their overbite or underbite being corrected, like I said, sometimes within 6 weeks. And everybody likes to start more patients, so we've seen a huge increase in annual starts in our practice as well. So we're gonna roll through this video here. So we're gonna talk about some cases down. What really got me involved in using the Motion appliance was basically I wasn't getting any AP correction in my aligner cases, and I was really, really struggling with getting bite correction with aligners. So I started implementing the Motion with a lot of my aligner cases. I'm going to show you a couple here. One in particular, this young lady, Josephine, came into my office, had orthodontic treatment. You'll see here in a second. She's got a lower 3 to 3N, and mom was just concerned about her bite. She was heading off to Taiwan for about 3 to 4 months, and I explained to her, well, you're a surgery case, and mom really wasn't up to doing surgery. So I said, well, can she wear an elastic and an upper SX retainer? And the mom said, absolutely, Dr. Chorak, let's try it. So we take a look here. Obviously, we got an anterior open bite. We got a lateral cross bite there on that right side. Midline deviated to the right there. We can see at least 3 millimeters. If we take a look at this case, you can kind of see we got the lower 3 to 3 in there, procline lower incisors, some upper crowding, and obviously, we've got some full cusp class 3 molar relationships right and left. So if we take a look, this is really the case that opened my eyes on what we can do here with the Motion appliance. Patient comes back 4 months later. She'd been in Taiwan, like I said. She comes in, and I literally dropped an instrument because I couldn't believe the correction we got here. And I brought all my staff over to take a look at this case, but she was wearing it 18 to 20 hours a day, changing it 4 times a day, upper SX retainer, lower class 3 Motion appliance. You can kind of see how well she wore the appliance because we've got rotation on that upper molar. But when we look at the uprighting of the lower incisors that were occurring, just by wearing the elastic. You can kind of see here in the buckle shots, we took that full cusp Class 3 canine relationship and kind of got her end on Class 2. And then on the other side, almost a full tooth Class 3 and got into a Class 1 platform. So what we did here is at this point in time, we actually removed the appliance, got her started in her aligner treatment. She's been in treatment now for 8 months, 4 months of motion, 4 months of aligners. You can kind of see we're rounding things out, lining things up. On the lower arch, you see how much uprighting we're getting of those lower incisors. You can see here we are 4 months into treatment, really getting some nice bite closure there, getting some eruption of those upper incisors. We're really closing the bite down, working on the smile arc here. And you can take a look here. So now she's been in treatment 18 months. Take a look, we're kind of really just kind of socking that bite in. Nice alignment on the upper arch. Look at the uprighting we're getting on the lower incisors. I mean, that's just amazing. That's one of the reasons why I really, it amazes me what we can do with aligners and how we can upright teeth, because we get that three-dimensional coverage of the tooth. But here she is right here. Get some nice Class 3 correction there. And like I said, here she is 18 months into treatment. So we take a look at where we started here. Procline lower incisors, that crossbite on that right side, midline deviation. Here she was at the completion of motion. And here she is right now, 18 months of treatment here, getting her socked in, working a little bit on that midline correction there. She's got a few more months left of her treatment. Here's a head film we took just recently. So you can kind of see what we're doing here is changing the occlusal plane with this appliance. And she couldn't be happier. And then, like I said, one of the harder cases that we got are these Class 3 open bites. I think it's a great alternative to surgery. Here's another case going the opposite way. We're going to show a Class 2 motion case here. So here we got Maddie coming in, pretty much done with her growth. We'll take a look here. We got 13.6. Got upper incisors that are procline, lower incisors slightly crowded. Let me take a look here. We got full cusp Class 2 molar on that right side and kind of almost full cusp Class 2 on that left. Patient wants aligners, does not want to go through braces. And when we take a look at her overjet here, we take a look at where she is as far as skeletal growth. I do use the CVM analysis to determine where kids are in their skeletal growth. I think it's a great way to determine, where they are, how much, growth modification we can do. Also, it helps us to determine when's a good time to start maybe the Class 3 motion appliance to where they're done with their maturation and growth. But she's got an obtuse nasolabial angle. I just did not want to extract on this case. And I said, well, let's try this motion appliance. And this girl wore her motion like you wouldn't believe. 6 months, usually what I'll go for when we're going for an orthopedic correction. I personally, how we do it in our office, we'll go full-time wear for 6 weeks on a Force 1 elastic, which is a 1/4 inch 6-ounce elastics. It's the Carriere elastics. That's the other thing that we need to remember is we got to use the elastics that comes with the appliance. And then we'll usually move into a Force 2 elastic, which is a 3/16 8-ounce elastic for 6 weeks. And usually at that point in time, we will get fully corrected into a Class 1 platform. A lot of overcorrection sometimes will occur. And then what we do in our office as a reward, we tell our patients that, you've worn it so well, we'll go through 2/3 of the day for 6 weeks. And at that point in time, we may go another 6 weeks just at nighttime. So I slowly start to take them off the elastic and just monitor if we're getting any bounce with their bite. So we take a look here. We took her, from a full cusp Class 2, and you can kind of see the overcorrection. What I'm really shooting for is to have that upper canine touching the lower first premolar. That's kind of what we're looking at there as far as overcorrection. We take a look here. Sometimes you'll get this reverse smile arc that occurs. That just helps you, either place the brackets or get the attachments where you need to get them to help level the arches out. So So you can kind of see the space creation, just like that one photo that we showed. These are the things that you should see if the patient's wearing their elastics. When we take a look at the lower here, you can kind of see the lower incisors are starting to line up. I don't use brackets anymore. I'll use a sidekick. It's just easier for the patient to hook up the elastic. It's not as bulky. It's not as high in profile. So we use the Henry Schein has a sidekick. It's called a sidekick, but it's basically a button that has a bevel to it. So the patient's easy to hook the rubber band up to. But you can kind of see the correction that we're getting here in 6 months. Got some nice profile change, good lip balance there. So here we are 5 months into aligner treatment. You kind of see we're starting to close those spaces, starting to consolidate, starting to really fix the proclination of those upper incisors. You kind of see on the lower right lateral there, we're starting to get some torque expression on that. And you can kind of see, really kind of getting that Class I platform established, getting that canine in the correct position. Here we are 11 months into treatment, and here we are 15 months into treatment. So, we really got that nice overbite correction, overjets being reduced, and we're working on this posterior occlusion to get socked in. We take a look at the arch forms here as we've gone through the process. They got some nice, lateral expansion there, just filling in that great lateral bone that she possesses. And on the lower, you can kind of see we got a nice axial inclination of those lower incisors. Everything's uprighting nicely there. Grabbing onto those second molars, lining those guys up. If we look at, the positive changes in just her facial appearance, we can see that, she's really transforming from where she started to where she's at here. And then we take a look. So total treatment took 20 months, 6 months of motion, 14 months of aligners. We take a look here. This is how I retain my patients. We do a bonded 2-2 on top, lower 3-3, and then we do Essex retainers over those. Instruct the patient 2/3 of the day for the first 2 months with the Essex retainers, and then nighttime wear every night for a year. After a year, we remove the 2-2 and then just give them an Essex retainer on top. So here we are, buccal shots, 20 months of treatment. So we look at the axial inclination. We got nice uprighting, nice Class I platform, nice profile changes there. And we take a look at the cephalometric before and after. Really nice change there with Maddie. Take a look at here. And here she is 7 months following treatment. So you can kind of see occlusions nice socked in there. Looks good. I mean, when you have great patients, you can really do some amazing things with this appliance, and we're going to see some more here. I'm going to just keep going. Perfect. So we're going to talk a little bit about Sebastian here. Similar situation from a Class II standpoint. When we're looking at a CVM analysis, I knew this kid was going to grow. So I knew that if we treated him and we kind of kept him in the appliance a little bit longer, we were going to get a little bit of an orthopedic effect. So this is the CVM analysis that I look at. So the CS3, CS4, that's kind of what I'm trying to treat optimally. When we take a look at that C2 vertebrae there, we're looking for that flattening to occur at the superior border, and then we're going to get a little bit of convexity there and a little elongation. So that's what I'm looking at. Same thing for your Class 3s. When we look at CS5 or CS6, that's kind of what we're looking for, treating maybe more along those lines, especially for your teenage males, that can grow a little bit later in life. So those are the things that I look at. We take a look, Sebastian had pre-proclined incisors. Take a look here. We've got obviously Class 2, right and left, and on. Mom was really concerned about his upper incisors being flared, so we really worked on that. And here we are. So this is following motion treatment. You kind of see we got that space creation between the 2s and the 3s. And you kind of see, like we talked about, overcorrection, upper canine touching the lower 4s there. And then we got him in the new SLX 3D bracket, which I love from a self-ligating standpoint. I think the far superior self-ligating bracket out there nowadays. So we take a look at here, we're lining things up, 8 months of treatment total here. So a couple months in braces. Take a look at the upper incisor inclination now. We're getting some nice uprighting of those teeth, filling in that lateral expansion. The beautiful thing about this appliance too is a lot of times when you get done with your motion appliance, your sevens have erupted, and they did in his case. So here we are 12 months into treatment. Hygiene's getting a little crazy. We're trying to make sure that we get him out of these things with minor decalcifications or none. So we're kind of working on his brushing, telling him to brush more. But here we are. You can kind of see a year into treatment, some nice uprighting of those upper incisors. Take a look at the facial change that occurred. And obviously this kid's growing, right? So, it's fast, it's easy, it's effective. Like I said, most of the hardest part of the bite correction is being done initially in treatment. So we get a lot of these bites corrected, and then a lot of it's just putting the brackets in the correct position to get the results that you want. So here we take a look at the profile changes that we got here with Sebastian. Obviously the kid's growing. We take a look here. This is motion was removed here, 6 months into treatment. Like I said, 2 months into SLX 3D, and here we are, 13 months, 6 months of motion, and total of 13 months of SLX, 6 months of motion, 19 months total treatment. So this guy is a little dear to my heart. This is my son Mason, who literally is as big as me, and I'm about 6'3", 200 and some pounds. This kid is 14 years old, and I wanted to show his case because I wanted to show a shorty being applied, and that's kind of what we did here with Mason. His canine wasn't all the way in on that left side, so we did a shorty on him, full Class II canine on that right side, and Mason plays on a traveling lacrosse team, so it was hard to get him in sometimes, so his treatment took a little bit longer, but I wanted to show you that we started him, before he was in his pre-adolescent growth spurt, which is key, because you're going to see how much this kid grew. But 6 months of motion with him. Yes, I'm just like any other parent out there trying to get the kids to wear the rubber bands. So, we try to positively motivate him, maybe a new lacrosse stick or something like that. I think that's how we got him to finally get through these things. But I always try to get on the sevens when we're doing motion, especially the shorties. When we're going to the fours, I like to get on the sevens. I had it on the sixes, but once the sevens were erupted enough, we actually got on those. So that was really good to get that. But you can kind of see we got the space creation. We got him socked in there on that Class 1 platform. You can kind of see the canines are erupted. You'll see this all the time on the shorty. If they're wearing these things, sometimes canines will be completely blocked out and you'll see these things. So those are the things that we saw here with Mason. Mason's got the new SLX. He had the SLX clear 3D bracket on the top. He wanted clear, so we did that. And then he had the SLX 3D bracket on the lower here. A lot of times you see those little blue molds. I'm sure you saw that with Dr. Carriere. So that's disarticulating the occlusion. One of the things we do is self-ligation. But like I said, it's a whole nother lecture. We'll talk about that if you guys come to the HSO symposium. There's going to be a lot of people talking about that. But here we take a look here. Alignment's looking good. Things are dialed in there. Kind of see we got some nice expansion there. Nice lateral expansion. And here we are, take a look, we're getting a little slippage there. Sometimes we need to go into an elastic, maybe 2/3 of the day or at nighttime, just to recapture that. A lot of times I'll use like a 5/16, 4-ounce elastic, sometimes something like that, maybe a Class II triangle, just to kind of sock that in. Here's Mason here, 12 months of treatment, 6 months of SLX there. Things are lining up nicely. Take a look at this guy, how he's growing, and then we take a look at the profile change on this kid. So, I think we as orthodontists, we need to look at, we change not only the AP, but we change vertical on a lot of our patients. You can kind of see that as these kids start growing. So here's Mason's head films throughout the process, and you can kind of see we got him at the right time, grew great, nice profile changes, good lip balance. And like I said, I think that's the key, is just treating these kids, especially if you want an AP, or excuse me, if you want an orthodontic, correction and take care of. That's just a great way to do it, is look at that CDM analysis. So take a look. There he is, and this is where he finished. So, overall treatment 20 months, 6 months motion, 14 months of braces there. Yeah, he's a good kid. So this case, this is a doozy. This is a really great case because it shows in a lot of cases, we don't see a lot of high angle cases, but you're going to see one here. Claire, great patient, did everything we asked of her. Second opinion, comes into my office, has a holding arch in, so we just decided to use it. You know, Claire was one of the first patients I treated with motion, but mom was pretty adamant she did not want to have teeth out, and I looked at her and I was like, oh well, she's borderline, you know, extraction here, and mom was pretty adamant to say, well, can she wear a rubber band? And she did. I mean, this girl really did, but you're going to see why I didn't want to extract her. If we take a look at her Class II molar end on right and left, Class II canine. This is where she finished after her motion appliance. So 5 months of Carriere Motion. We take a look, obviously we developed an open bite with her. I'm not concerned about this because with self-ligation mechanics, this closes up really fast. We take a look at the lower crowding. You know, even with the holding arch, you know, the lower incisor stayed relatively in the same position, but you can kind of see the space created with her. I did go up to that canine. You know, like I said, I was new to it. I decided to attach to the canine rather than to the premolar. Premolar is a little bit blocked out. You can kind of see palatally, so that could be one of the reasons I did that. But look at the improvement in the proclination and the crowding. And obviously, we overcorrected with her. I mean, almost all the way Class 3 there. But you can see the improvement there. I mean, you'll see spontaneous alignment with this appliance. I mean, it's amazing, the space creation that you get here. Obviously, we've still got good lateral bone support to capture. And we take a look here at the lower, you can kind of see, you know, I mean, relatively lower incisor stayed in a pretty good position. Obviously, you can kind of see even with the holding arch, we're able to get the sevens to erupt. That's great. So you see the changes here. That's the reason why I didn't want to extract this girl. I mean, she had just a streamlined, you know, very obtuse nasolabial angle. But that's what we got with her in 5 months from a profile change. And this is what we got here. So we take a look here. So she's 2 months in SLX brackets here. So you guys see that bite just closes down. No vertical elastics or anything like that, or an anterior elastics. It just naturally will close down with light forces. We take a look here. We are lining things up. Obviously, we've got teeth coming in there, lower right 5. So here she is, 12 months treatment, overall treatment, so 5 months of motion, 7 months brackets. Things are lined up nicely on her. Capturing those second molars now. Obviously grabbing that lower right 5. Take a look, obviously we're making some positive changes with the profile there. Here she is, 14 months of total treatment, 9 months of motion, 9 months of SLX, 5 months of motion. And here she is lining up, looking really good. Just utilizing that lateral bone support. Here she is, Class 2 molar. You know, we're getting her in that Class 1 platform, so staying corrected, looking good. Her incisors looking great. So if you take a look here, got some nice coupling there in the anterior there, and a really nice coupling in the posterior there, just socking things down into place there. This is where she finished here. So a really nice response. Obviously, you got to have great patients that give you these results, and Claire was a great patient. I mean, here we are. Here's her cephalometric change here. You know, just such a positive change, and she was a great patient. You know, and you know, no root resorption, any of the incisors there or anything like that. So when you're using light mechanics, light forces, and you're really jumping on that bite correction right from the get-go, that's what we always see in our office. And it's just a lot of praising. Patients come in, it's a lot of, you know, positive reinforcement that they're doing a great job. You know, if they need some help and some, some positive reinforcement, we're going to get them through that. But a lot of it's just, developing that compliance with your patients to get them to where they need to get to. So, here people have asked me, can it correct a 10 millimeter overjet? Absolutely. Yeah, absolutely. This thing can do anything you ask of it, really, when it comes to overjet or underbite correction. But here we have, obviously a patient, 80% overbite. You'll see here, class 2 molar canine relationship, and I think we measure, I think she was right at 10 millimeters of overjet. I always look at, when we do our initial exams, I'm always looking at molar rotation. Obviously her upper molars are rotating. You kind of see she's got the retained E's on top there. That's one thing that we always look at now during our exams. Here she is. You can kind of see the lower 7s are erupting like we talked about. But here she is, I believe 5 to 6 months of motion for that orthopedic correction. And here she is. So we take a look here. So she was 15 months of SLX 3D, 6 months of motion. Here she is finishing. So we got a really, really, really nice response here. Lauren is just a dynamic, amazing patient. When we take a look here, when we got this overbite correction, these are looking great. And here we are, profile changes. So we're going to take a look at another case here. Maddie, another great patient here. Very unique in the sense that she's got a blocked out canine on the right side, but you'll see here in a second, she's kind of class 2 molar on both sides, class 2 molar end on that left side, blocked out canine on the right side. Take a look at here, 6 months of motion. I was trying to get an orthodontic correction there. Got the midlines corrected, made space for the canine, and obviously created space there for the class 2 on the other side. Got some spontaneous uprighting of those upper incisors. You'll see that all the time with that S6 retainer. And here we are, class 1 platform established. Midlines corrected. It's got nice overbite correction there as well. And you can kind of see she's still got great lateral bone support there. Lower arch looks good. You can kind of see the lower incisors stayed relatively in the same position. And here we are, class 1 platform, right and left there. And it's just, now the case is easy. I mean, now it's just a matter of putting the braces on correctly to give you the mechanics that you want. That's kind of what we did here. You can kind of see we bracketed, kind of started working on that reverse malar. So she's been in braces now, or total treatment, for 12 months. I've got some bite turbos on her there, running some vertical elastics just to kind of help with the overbite correction. Kind of see things are flattening out. So 6 months of motion, 6 months SLX. And here she is. So 9 months of SLX now, 15 months total treatment. So reestablishing that smile arc. She's lining up great, doing everything we're asking her to do. Second molar is coming in. And here she is. Great alignment, bite socked in, overbite looks good. We take a look here. Really, really nice coupling there in the posterior, bite socking in. Axial inclinations are looking great. Positive profile changes. And here she is. So I presented this case at the symposium. This is the day of debond. So 18 months of treatment. She's just a great patient. You're gonna see a lot of these corrections, are from really, really patients that buy into it, because a lot of times, like I said, they've seen their overbite, they're seeing their overjet being corrected with the Demotion Appliance, and they see it. Parents see it, their friends see it. So we take a look here. Great profile change here. Lips are in a better position. Just kind of recap here. Just wanted to show you the blocked out canine, deep overbite, midline correction. Here she is 18 months after treatment here, 5 months, like I said, motion. Day of debond, here we are 3 months at her retainer check. You can kind of see everything's still locked in, looking good. I love following these patients long term and just really seeing how things look, right? Because everybody can show a case at the time of debond. Let's see how they look 3 months out. Let's see how they look 10 months out. Well, here she is 10 months out, still looking great. Things are lined up, awesome. You know, mom's getting ready to start her second daughter, so we couldn't be happier. Another case. Take a look at this one. It's amazing what you can do when a patient comes in who's a freshman in high school, and she basically said, I need what? And this is going to take how long? Because I do not want to start my sophomore year in braces. So I told her, I was like, well, we gotta wear this appliance. You know, you're a full step Class II molar, and she did. This girl's a cheerleader. You know, she was just, you know, all on it, wearing it, changing these rubber bands, doing the things that we asked her to do. So we take a look here, 6 months. She, you know, she's just creating that space like we talked about before. 6 week intervals, horse ones, full-time wear. I have them change it after breakfast, lunch, dinner, and before they go to bed. At least 4 changes a day. That's our protocol. I have them wearing it 18 to 20 hours a day. Followed up by force 2, that second appointment. So you kind of see no flaring of those lower incisors. Here she is, 6 months. So we get her going. 13 months total treatment here. We've got some bite turbos just to help kind of level those things out. And here she is, 15 months treatment. So 5 months of motion, 10 months SLX. We did make it in time for her not to start her sophomore year with braces. So here she is. Great profile changes on her. You're going to see here, I mean, it's just amazing. You know, you're wondering what's happened there on these non-growers, but I think it's a little bit of it's that recapturing the disc. I do think you get a little bit of remodeling the fossa up there. Here she is 3 months into retention. Things looking great. Everything's still holding up. And here's her profile shot here. When we talk about mixed dentition cases and face mask therapy, I don't use face masks anymore. I think they're hard on the patient to follow, to sleep with these things. We're now using a Class III motion appliance in combination with either a W-arch or an expander. This kid obviously has a skeletal issue. You know, basically you're going to see here, Joaquin here, got some definite crowding on top. Obviously we have pretty much the entire maxilla sitting inside the mandible there. We ended up putting an expander in this kid. He does have a W-arch now in there just to hold things. But this is the thing I like to use now as far as my go-to appliance for the mixed dentition underbite, where they have, you know, significant amount of an underbite, you know, negative overjet. So you can kind of see what we got going on now. Just got this quadrihelix W-arch here. One thing you see, we disarticulated the bite in the anterior with some bite turbos and also in the posterior. This case is going to be great to show here in a few months because we removed the Class III motion appliance. He's in brackets now, full dentition. This kid just started losing his teeth left and right, so we just transferred him into a full case, but he's looking great now. And I think we might be able to pull this off non-surgically. So Monica here, captain of her cheerleading team. Similar situation, she was actually heading off to college, so I had about a year to get her treatment done. And obviously she's pretty self-conscious of her bite. You know, she's smiling here, is not even showing her teeth. But you can see the upper three is blocked out. We have a significant underbite. She does have a CRCO shift. A lot of times you'll see that on these overbites that are deep, but have an underbite. So what we ended up doing on her is we just started creating space. Put a Class III motion on her, disarticulated her bite in the anterior. You'll see this here. So you can kind of see, we're starting to smile now. Yeah, she's happy. So obviously, you know, we still have progress to make on that 3 that's blocked out, but she's doing a good job wearing her elastics. You can kind of see we've got some disarticulation on the bite, molar pads on the 7s there. But we got it jumped. At this point, you can kind of see we've got correction there to a Class II canine relationship. And that's kind of what I'm looking at as far as my Class 3s. I try to get end on like that. And here she is, so 7 months into treatment. Look at the positive overjet changes there. Let me take a look. The lower incisors there. Didn't create some space there, and obviously we've got to get that Class II corrected now. She's got a little bit of a crossbite there on that right side. We're going to work on that as well. A lot of times what I'll do on those cases is we'll just do a little cross arch elastics there in the posterior just to get the bite jumped, disarticulate the bite there with some molar pads on the 6s. Here she is, 12 months treatment. Like I said, she's leaving for college. Mom said she took a job over there in Eastern Washington. So when she does come in, I want to get some follow-up pictures on her, but she's happy as can be. Upper and lower alignment looks good. Have her in an upper wrap around retainer. Normally I don't do those, but I knew I wasn't going to be seeing her. I knew we were going to get some settling that would occur. So, but overall, you know, this girl's happy. So I'm going to run through some cases really fast, okay? Because I have these cases. I wanted to get through these 10 cases just to show you some real difficult cases. You're going to see a whole bunch of different cases that we're using now with the new SLX 3D bracket. You're going to see how fast these cases are occurring. But I'm going to go through these very, very quickly just because I know we're going to be short on time. And I'll be happy to explain how we treated these, you know, in March at the symposium. But we're going to take a look here at this first case here with Samantha, obviously similar to that last Class 3 case. It's got the mixed dentition going on here. We take a look here, and you can kind of see you are going to get uprighting that lower canine. It will get mobile, and you just have to explain to the patient that that's the process that occurs with that. She did a great job wearing her Demotion Appliance, and here we are in SLX, and here we are finished. You know, 21 months total treatment. You know, 5 months with the motion, you know, 21 months total, 16 months of the SLX. Remember, she was in the mixed dentition, so that's the reason why this case took a little bit of time. But you can take a look at the profile there. Another Class 3 case here, 4 months motion. Here we are. Here she is, 2 months into retention. Another case here. This is what I'm talking about with overcorrection. Obviously, you can kind of see we overcorrected him quite a lot. He's getting close to being done here. I mean, I see this every day in my practice. Here's a Class II Div II. This girl did an amazing job. Here she is, 12 months in treatment. To go from that Class II Div II to here in 12 months. Here's another one. People say, well, she's in crossbite. I'm like, oh, yes, she is, but she's also has her 3s that haven't come in. And we got to look at things 3-dimensionally with our patients. You know, it's not just about transverse, it's about AP. And when I looked at this girl, all I did here was make sure that we disarticulated the bite there in the posterior, started using a shorty on her, and all of a sudden 3s start coming in. Another case here, we're using a shorty, canines are dropping in. This one you can kind of see here, we have a canine that's completely blocked out. Look how well this girl wore her elastics to create that space. And here she is, 12 months, 11 months of treatment. or you have somebody here who's either congenitally missing a lower left 5, or maybe it was an E that was lost, but you look at the case, the patient's Class 2. So, we throw a motion in there. Here she is, closed down in front there. Or something like this where you have a full cusp fractured incisor there on that upper left central. I mean, these are the things that we're doing every day in our practice, getting this nice AP correction in a short amount of time. So I just want to reiterate that the incorporation of the Demotion Appliance with SLX 3D mechanics and self-ligation, it's very fast, easy, and it's very effective. And these are the things I like to do. Love to travel with my wife, Marilyn, who we've been married to for 24 years. On our 20-year anniversary, we went to Bora Bora. If you haven't been there, it's amazing. And love traveling with my family. We've been to Rome 2 years ago and Greece this past year. But I really believe that, if you can think it, it will happen in the sense of Class 2, Class 3 corrections in your office. Just developing that mindset of having this as your go-to appliance. And then once you get the bite correction, it's just about placing the brackets in the correct position to get the treatment outcomes that you want. So I'm putting my email address up there, and I'm very open to helping doctors out. So please write it down, take a picture. It's toothtwist@comcast.net. And I love educating people. I love, positive, results and positive feedback and stuff like that. So if you guys do have questions, you can reach out to me. And I'm very good about getting back to you in a timely manner. So thank you so much. Really appreciate your time today.
All right, thank you, Dr. Chorak, for that. We have some questions from the audience. The first question is, what is your bonding protocol for the Carriere appliance that avoids the breakage issues?
Yeah, so what we've done in our practice is I've taught my assistants on how to, isolate the patient. I've got 2 very busy practices, so I do delegate my assistants who are trained very well to etch and prime. We use the NOLA cheek retractors, but we don't use the tongue retractor. We just use a small suction. People have been in my office and see how we do it, but as far as the metal one goes, we etch and prime. I use just standard etch. I think we get our etch through Henry Schein, but we use Ortho Solo as our primer. And then the key is when you're putting the adhesive on the pads, you want to put a large amount on there. You don't want to just like you're putting a bracket, a very, very thin amount. So a very gracious amount of adhesive on the pads. And then what I'll do is when we put it on there, I'll have the assistant place it. They'll call me over. I'll wipe the excess off. If there's any rotations on the canines or the 4s, you do not want to bend the appliance into the rotation. That's going to throw the vector off. What we do in our office is we take a flowable composite after we've cured, and we just backflow the composite into the pad, and that's worked great for us. Now, when you're bonding the clear, it's a little different. You can do it 2 different ways. You can either bond the molar pad first. I know Dave Paquette does this where he just moves the arm out, adds adhesive to the canine pad, and then pushes in with the instrument. I've got very big hands, so what I end up doing is molar pad my fingers and shield the cuspid as we're curing the molar, and then I come in with a ligature director and push the arm into the cuspid area. Those are the things that you have to do with the clear motion to get that pad to integrate. And then, like I said before, I love to just take some flowable composite and just backflow it in there. That works really well in our office.
Great, thank you for answering that. The next question is, this is going to be in regards to earlier in the presentation when you were talking about the Class 3 interior open bite. Hey Mario, great case, super impressive. Would you try the same approach in a 45-year-old female, class 3 anterior open bite? Thanks, Carol.
Yeah, I would. I mean, I think, options, obviously you need a good compliant patient. But remember what we're doing with this appliance is we're changing that occlusal plane. So as long as we have the understanding of, obviously surgery is always an option. And in that regard, we're not taking teeth out. We're not decompensating the patient that way for surgery. But I've got another patient, an adult female patient, probably in her late 30s, who's in a class 3 motion appliance right now because they couldn't afford surgery and they wanted to know if there was another option. So, that's the way I look at it, as it's definitely an option for a patient to not have to go through surgery. If you guys have seen Dr. Carriere's class 3 cases, there's some significant adult class 3 corrections and that didn't go through surgery and obviously got a really, really nice result. But my whole thing is when we're doing these class 3s, make sure that we are extracting the thirds, the wisdom teeth, especially the lowers. It's gonna help with our class 3 mechanics. But yeah,
awesome.
Try it.
Yeah, why not?
You got nothing to lose.
So the next question is, this is going to be shortly after that question was asked. I didn't get the case she was asking about, but she wanted to know, no need for a lower FLA, just a button on the first molar to attach an RB. Do you know exactly? That one might be a tough one. I might have to go back and
for FA.
Yeah, FLA. We can always revisit that one.
Sure.
We'll revisit that one. Sorry about that. The next question is going to be, how do you scan/take impressions for the aligner making when you finish the motion phase? So she is asking going into aligners with the motion.
So we do it a couple different ways. I'm using a lot of the SLX aligners now in my cases, which is, I really like that aligner. So how we're doing it in our office now is once we're done with the motion phase, we're actually, we are removing the motion appliance, and then we are either impressing or scanning for an SX retainer, delivering that usually within a day or two, and then waiting for the aligners to come back. I will say the cases that I've done that on, when the aligners have come back, they've all fit really, really nicely. A lot of it, what we're talking about is making sure we overcorrect. So that's the key. So, but I'm not keeping them elastics or anything like that. I used to, with another aligner company, have them virtually remove the motion appliance, have them wear an elastic, usually a lighter elastic just at nighttime to hold the AP correction. That was our old protocol.
Awesome, thank you. And then the next question is going to be, hi, Dr. Chorak. As you are sharing kids' cases, I would like to know what type of retainers do you use and why for these developing patients?
So what we end up doing is I think I mentioned my protocol as far as retention. We do an upper 2-to-2 bonded retainer and a lower 3-to-3 bonded retainer. Then what we end up doing is we deliver those at the time of debond. We bring our patient back the following week to either scan or impress for SX retainers, and then usually we'll see them back a week or two later to deliver those retainers. I like doing it that way, just to allow the bite to settle a little bit so you don't get that rebound effect sometimes you get with SX retainers. It's a great way to let the tissue heal up. That way you're not remaking these SX retainers. A lot of times in our phase 1 treatment, or if we're waiting on more permanent teeth to come in, we'll put them in either an upper 2-to-2 SX or an upper Holly. Kids like the colors and the designs that they can pick. But those are really the retainers that I'm using in my practice. It's my go-to retention protocol. We see our patients back 2 months, 3 months, and then 6 months. So we follow them for a year. Like I said, at that year mark, we have a discussion with the parent or the patient about removing the upper 2-to-2 and then just giving them an SX retainer.
I know we've talked about this a lot, but when it comes in regards to carrier motion, where is the ideal placement of the motion on the canine?
Yeah, so the ideal placement of the motion on the canine, and that's a really good thing to remember, is I personally, I don't like to go after high canines. I think that can cause a little bit more of a vertical change, and if you're trying to avoid, showing a lot of gum display, you kind of want to look at that. So if the canines are displaced vertically, I will usually use a shorty. When I'm looking at the bar there, I'm trying to get that basically parallel to the occlusal plane. So that's what I'm really looking at there. And as far as where to place it, you want to place it as mesially as you can. Sometimes when the canines are rotated, when we look at size-wise, how to size these things, and you teach your staff these things, is if the canines are usually rotated distally, you're going to usually pick a size bigger. If the molars are rotated more mesially, you're going to pick a size smaller. So those are the things that we kind of teach our staff. I hope that answers the question.
Yep. Kind of to segue into our next question, is there any hesitation using a cuspid demolar on one side and a shorty on the opposite side?
Not at all. I mean, a lot of times when we're looking at those things, like that one case on Maddie, she had a canine that was obstructed on one side, and so we did use a shorty on that side, and then we used just a regular size motion on the other side, and you saw how well her treatment turned out, and with her midline correction and stuff like that. So absolutely, if you have a blocked out canine on one side, but you just have, a Class II canine relationship on the other side, yeah, like I said, that case we did use a shorty on one side and a standard length motion appliance on the other side. So absolutely, there's no need to worry about having to use, shorty on both sides on those cases. So.
Great. The next question is going to be, in the case of mixed dentition where there's no space for canine to erupt, you put the motion device on first, the premolars. Is it okay to distalize premolars while they still have an open apex? Or should we wait for the apex to close first?
It's a great question. I've had patients who've come to my practice with primary teeth that are still present. And usually it's, 6th grade, 7th grade, 8th grade, maybe right around that middle school time, but they aren't losing these teeth. And the first thing I look at is, the molar relationship, obviously, and then we take a look at, are those molars rotated? So I've done cases where they are in mixed dentition, they are a little bit older. I think, when we look at apex development, I look at that in my early cases when we're putting brackets on 2 to 2, can we wait 6 months to let those roots develop and have those apexes close? So I don't think it's a bad idea to let that development occur before placing the motion on those cases. I mean, as you can see, some of the cases that I showed, we had full cusp Class II molars, and obviously I didn't treat that in the mixed dentition. So we can correct these things a little bit later. I personally, I don't use a lot of Class II motions in the mixed dentition in my office. Not to say that you can't, but I usually will use it if we have severely proclined incisors with no spacing in the anterior, and usually I'll hook it up from the canine if it's present. If it's not present, we'll go from the D. Just remember, if you're going to use the motion in mixed dentition cases, you don't want to go anything bigger than a Force 1 elastic, and I would start them off with a lighter elastic, maybe like a 5/16 4 ounce or 6 ounce, maybe move it into a 1/4 inch 6 or 4 ounce, and then if you need to have that Force 1, because those canines will get mobile, and sometimes you'll be sectioning the motion appliance off a primary canine. I've done that a couple times, so hope that answers.
Yeah. Dr. Chorak, it looks like we're running short on time, but to those who have not had their questions answered yet, please write down Dr. Chorak's email there at the bottom. He's great at responding to emails and questions. Like he said, he loves teaching. We just want to thank you, Dr. Chorak, for your time today. You're awesome. You're killing it right now with the Carriere Motion. That's SAGITTAL First Philosophy, and it's exciting stuff. So thank you.
Yeah, well, thank you guys all. I appreciate presenting, and everybody have a great weekend. And like I said, you can reach me at toothtwist@comcast.net. I hope it was meaningful. I hope it kind of opened your eyes on what we can do as far as the SAGITTAL First Philosophy, Carriere Motion, in combination with self-ligation mechanics. So take care. Thank you.